So I'm going to talk to you about a virtual healthcare delivery system built on community care teams. This is actually called Southern Prairie Community Care. And before I get into that, I'm going to give you a little bit of the history about the innovation that's been going on in Minnesota. So in 1993, the Institute for Clinical Systems Integration, what we lovingly refer to as ICSI, started out as a guideline development group, and a lot of folks from around the community said, guess what, we're all working on guidelines, we're all writing our own guidelines, why don't we come together and do this collectively? And so in a collaborative manner, very collaborative manner, that started out in 1993. It has grown to, I don't even know how many guidelines they have written now, but they also provide learning collaboratives, improvement initiatives, and so forth, and really helping to support the provider groups across the state. So it's really become an extremely collaborative effort. So I think that one of the things that I want to say about Minnesota is that our collaboration and the tendency to be much more collaborative has really helped us be much more innovative. One of the first guidelines that was developed back in 93 or the early 90s was the diabetes guideline, and I actually sat on that committee for at least the first 3 editions. I can't remember how long I was actually on that group, but for at least the first 3. Then we have Minnesota Community Measures, which started in the year 2000. And again, the providers all came together and said, you know what, all the health plans are trying to measure quality, and they're doing it in slightly different ways at different times of the year, and we need to bring this together collectively. So again, there was this collaboration that came together and said, let's create community measures. So now all of the health plans in the state of Minnesota are using the same measures, and the one that we have related to diabetes is a composite measure, and we'll talk about that in a little bit, but that is referred to as the D5. So it's a composite of 5 measures. The other thing that's been going on in Minnesota are counties coming together, basically county-based purchasing plans. So these were counties that came together and created their own health plans to serve primarily the Medicaid and uninsured populations. That was occurring in the mid-1990s. And the Palenti administration, which was a Republican administration, limited that expansion of those county-based purchasing options in 2006. So then when Dayton came in, who's Democrat, not sure if those have anything to do with how these decisions were made, but basically shifted that reform focus to ACO development instead of health plan development. So that occurred in 2011. So this all sort of provides the background for how Southern Prairie came to be. DHS then, the Department of Human Services, put forth RFPs for some demonstration projects in 2010. The primary goal being to encourage innovation to deliver higher value care. We've all been talking about that today and yesterday. And then looking at some secondary goals of looking at how to support robust primary care and care coordination via healthcare homes or equivalent efforts. In Minnesota, we refer to the medical home as a healthcare home. Also looking at testing payment models, so looking at different ways of payment. So all the things that we've been talking about related to payment, said how can we do that differently with provider accountability for the AAA. And then implement projects in different parts of the state, so they wanted it to be statewide, to allow participation of both larger and smaller provider groups, and then to create alignment with similar initiatives across payers. Interestingly, and probably not surprisingly, that most of the initial responses came from the large integrated systems. They basically were doing positioning. We saw a lot of folks coming together that some of the larger systems were trying to acquire some of the smaller clinics or smaller medical groups. And the folks from DHS were concerned about that. They were particularly concerned about the safety net providers and losing that group of providers. So they began to promote the idea of a virtual ACO or healthcare delivery system. So this is where Southern Prairie Community Care came to be. Southern Prairie Community Care actually is a collaboration of 12 counties. They began their discussions in 2006, considering the county-based purchasing plan option. And if you look at this map, down on the bottom left here is where Southern Prairie Community Care is. All of these others are county-based purchasing plans. They are health plans. Southern Prairie is not a health plan, so I'll describe what they are. They're more like an ACO, healthcare delivery system. What's really important about this is to acknowledge that this was county-based initiated. So county commissioners came together and said, we are spending too much money for the patients that are falling through the cracks. And a lot of folks say, well, how can that be that the counties are picking up the tab? Imagine someone who's on psychotic meds and they're not taking their meds, or someone who has a hypoglycemic reaction while they're driving and they end up in a car crash. Department of Corrections. People end up in jails. People end up involving the Department of Corrections because of not being able to take care of, they're not taking care of their health needs. Also, all of the county-based services, public health, social services, and so forth, oftentimes end up picking up the pieces for a lot of these patients that are not being taken care of. The thing that I want to point out is while these folks came together in a joint powers agreement, they're not a health plan, we did engage with all the providers in the community, and the providers in the community are part of a gain-sharing arrangement with the state. So Southern Prairie is in a shared savings model with the state of Minnesota. With the savings that we gain, we are going to share that with the providers that are in the community. And that there's a calculation for how that occurs. So our guiding principles are that we will build upon the local partnerships. There are a lot of partnerships that have already been occurring. Increase the local control for this and not have it happening at the state or even with the health plans. So the health plans that have been providing the coverage for these residents are still involved as third-party administrators, and in some cases they're helping with some of the implementation, but for the most part it's Southern Prairie who is doing the care coordination and so forth. Focus on early intervention and prevention, so it's really moving that dial backwards. Further the integration between medical and county services, building on the strengths and challenges of delivering the services in a rural area. This entire area is rural, mostly farming communities. People have to drive significant distances to see their healthcare providers. So when we talk about pharmacists in almost every community, we have definitely involved the pharmacist. And then we also have issues such as 11 of the 12 counties are considered food deserts. So we have those issues as well. So we're looking at social, psychosocial, and economic issues as well as their healthcare issues. And as we have the savings that we hope to incur from this, that will be brought back into the system to continue the improvement. So we know that there's this shift in the cost of care, and this is no surprise to anybody that we expect that the cost to go up. And this is what the county commissioners said. We know the cost is going to go up. It's been going up every year. How can we bring it down? We also know that from a provider standpoint, you're seeing revenue going down. So how do we make sure that we can actually improve that picture? And we're going to look at the accountable cost forecast. And basically in using an accountable community care team approach, using coordinated transitions of care, analytical reporting, and managing those episodes of care, especially between visits, that we hope to improve that total cost of care picture. Our primary focus right now, because this is a demonstration project with the Department of Human Services, that it is on Medicaid. Our next steps will be that we will be incorporating the entire population. We are already starting to analyze the entire population to get a better sense of what we've got going on there. But as everybody has said, our primary focus is on those frequent hospitalizations and ED visits, so looking at how we can reduce those. We know that some of the drivers for those are mental health and chemical dependency diagnoses, as well as those with dual diagnoses. So we're focusing on those folks, and diabetes and prediabetes, because this particular area has a higher prevalence of diabetes than the rest of the state. So I like to tell stories using patients. This is Bill, and Bill's a 55-year-old male. As you can see here on the left-hand side, he has a lot of things going on, and there was a comment made about silos, and do we just take care of diabetes and then we take care of COPD and other things in separate silos? And this whole entire concept is to say, no, we're really not going to do that. We're going to take care of Bill. And when we look at population, what we need to think about is that we manage populations, but we take care of patients. And so when it comes down to, in that patient right in front of us, Bill has a lot of things going on. He may fall into the diabetes population, but he also falls into a lot of other populations, if you will. And he has a lot of needs that we want to make sure that we address. So if we talk about Bill's current interaction with the healthcare system, he's had multiple hospitalizations, and I don't have enough space on this slide to show the number of hospitalizations in the last several months. And in between hospitalizations may go to subacute rehab. Then when he goes home, he needs home care, PT and OT. He needs some transportation assistance, meals, durable goods, and equipment. He also has dialysis. He sees a nephrologist for that. Of course, he has his PCP, who refers him to a number of other specialists. He goes to a diabetes educator, and just about every provider is going to prescribe him a medication. And so the pharmacist may be the only one who has the most global picture of what's going on with Bill, unless he's going to multiple pharmacies, and we know that happens as well. So if you think about this, not only in terms of Bill going from place to place, and you look at those lines as Bill going from place to place, but also think about information. And you think about how can we exchange information from place to place, because oftentimes there is not a strong connection between each of these providers. The home care may not even know what's going on in the PCP's office or the healthcare home. So we said, there's got to be a better way to do this. And I know this is a complicated slide, but let me walk you through this. So if we start over here on the right-hand side, your left-hand side, my right, we have information that comes from the Department of Human Services. So it's basically all the claims data that tells us, first of all, who are all the patients who are attributed to the Southern Prairie Community Care providers, the network. And once we have that information, then we assess that population, stratify it by PCP, because our attribution model is based on primary care provider. First stratification is with a healthcare home. If there's no healthcare home claim, then it goes to the PCP. If patients don't have a PCP, we are encouraging the people in the community and the Southern Prairie folks to help them engage with a primary care provider, because we know that that's really an important component. Then that information is sent to the PCP in the healthcare home to identify their participants. So now the PCPs will know who their participants are. Then they will do further analysis of those patients and do a stratification based on their needs, because we're not going to be able to provide intense care coordination for everybody on the list. And we also know that not everybody needs it. So we look at those folks, then we do some categorization based on their needs and level of risk. If we come down here to the bottom, which says care coordination intervention approach based on a care plan created collaboratively with the patient, family, the primary care provider, and healthcare home care team, care coordination as appropriate, drawing upon the community as needed. This is where all of the rubber hits the road, and this is where all the work needs to happen. So you're going to have low-risk patients who just need usual care, reminders about preventive services and so forth, and that's really about it. Then you're going to have some folks who are in that intermediate risk category who might have risk for something like diabetes, so you would encourage them to get involved in lifestyle management, lifestyle risk reduction, that kind of thing. Then you have the really high-risk folks who are going to have intense care coordination, and we will apply our resources based on that. Now notice that I did say including the community as needed. When we come up here on number 7, we're going to review the participant status, but that is including the information that we get from the community providers as well. We have a health information exchange. We're in the process of implementing the health information exchange, which will exchange information not just within the healthcare system, the providers, but also out in the community with all the folks that are involved with them as well. So public health, social services, mental health, those folks will be involved in that health information exchange. And then there is, on a regular basis, that periodic review, and we're actually going to be getting this information on a monthly basis from the Department of Human Services. This looks really messy, doesn't it? But I'm going to tell you, well, first of all, when we think about healthcare, is messy. And so this is based on the chronic care model. And I want you to look at first this bubble right here. This bubble is all about all the healthcare organizations. So as I said, we have 12 counties, but we've divided them up into 4 communities. Each of those communities is comprised of hospitals, primary care providers, behavioral health homes. We talk about them there. So basically a mental health provider. We may have diabetes education. Not all of our communities have that, so we need to include that. But this is what's within the healthcare organizations. This is what's out in the community. And all the time, constantly adding to this. So we've got health policy and MDH and DHS, obviously they're out here, but look at, we've got correctional systems. When we have our community care team meetings, our work groups are bringing folks together, corrections shows up. Corrections tells us what happens when these patients come in and they don't have access to any medical records. They all will have a medical director, but to access that information is almost impossible. We have employers at the table, public health, adult daycare, assisted living, and the list just goes on. At the center is the patient and the family with a quarterback, what we call a quarterback, that may or may not be the care coordinator in the primary care's office. In the primary care provider's office, as has been said already, oftentimes patients are only in that office maybe 3 or 4 times a year. But they are oftentimes being seen by folks in the community, sometimes as many as 3 or 4 times a week. We have mental health providers who will go to the home. There are teams who will go into the home 3 to 5 times a week. So there are a lot of people who are seeing these patients a lot more frequently than the primary care provider. And we're sort of calling them the quarterback. As the team says, you know what, you're out there more often than we are. You let us know. You be the eyes and ears for the team and let us know what's going on. But what really makes this work is this information flow back and forth. We've got to exchange the information. And obviously, as with the chronic care model in general, that really what we're looking at is that we have informed, engaged patients and a prepared, proactive community partners who can really help support that patient to get to the outcomes that they want to have. And the idea of selecting who that quarterback is, that's really part of that is helping the patient decide who that person should be. Who do they have the best rapport with? Who's the person they feel most comfortable with? As has been said already, oftentimes the patient is not willing to share everything about what's going on in their life with every person on the care team. And there might be one person they feel more trusting with. So we really want to make sure that we hone in on that. Really managing care transitions is an important component of this, so coordinating that patient and family-centered approach. For the clinicians in the room, treating to target is something that we're very accustomed to thinking about. We're taking this more to the community approach as well and saying this is about treating to target. And sometimes treating to target is not just about medical and clinical issues. It's also about making sure that they have affordable housing, that they have an affordable wage, they can get healthy food to eat, and that sort of thing. For some of these folks, their needs are so very basic. Collaborative goal setting and communication, making sure that we're all saying the same thing and we're on the same page, because it's not uncommon for patients to get a different message from different persons who are providers of their care team. Going back to Bill, it would not be uncommon, let's just real quickly go back to his slide right here. It would not be uncommon for Bill to have 5 or 6 different care coordinators. And in some cases, I have seen as many as 19 care coordinators. That means there's 19 different care plans. And in most cases, those folks are not talking to one another. So they might get a call from the health plan, they're getting a call from the hospital, they're getting a call from the primary care provider, they're getting a call from home care, and the list goes on. In this case, he's probably got a care coordinator for his dialysis. How do we coordinate all that? So that's what we're trying to accomplish here with all of this. So looking at a patient-centered information exchange is really what we're about. The other piece is this piece about everyone working at the top of their licensure. We want to make sure that we are using people in the best way possible and that we're not asking people to do that. In many cases, RNs are being asked to do stuff that could be done by the secretary or the receptionist. And it's not uncommon for the receptionist to say, you know what, I'm willing to take that job on, because they want to be part of the care team as well. So here's Bill's community care team. And you notice that we've got all these folks up here in the healthcare organizations, but we also have folks out here. Now, we may not include Meals on Wheels in our health information exchange, but we need to know that they're involved. But we will include subacute rehab. We will include his community mental health. We will include community pharmacy to the best possible way that we can. Dental. Dental is a huge issue. I really haven't heard much about dental here, but in some cases, the folks who come into the ER visits, 60% of those might be related to dental pain, particularly in rural areas where they don't have a lot of access to dental care. This is the care measure that we use for diabetes, the optimal diabetes measures. As I mentioned, it's called D5. And so it's these 5 measures: A1C less than 8, blood pressure less than 140/80. This is what the current one is. I know that the ADA has changed their recommendations, so we have to wait for Minnesota Community Measure to change theirs as well. I'm sure they will. LDLs less than 100, aspirin, and then non-smoking status. So this is a composite measure. It's all or none. So in order for the providers to get credit for this, they have to achieve all of these. And yeah, that's a tough thing to do. You got to remember that in Minnesota, we've been doing this for a long time, at least 20 years. So we've been through all the anger that many of you are dealing with, all the frustration and all the game playing and everything. Our providers know it's not going away. It doesn't mean that they're happy about it. But we're also looking at other measures. The questions have been risen about, what about those socioeconomic issues? What about when someone they don't have a home, they're in transitional housing, they don't have a job, they have other issues that are compounding this that the providers, the primary care providers, cannot control. And that's why it's so important for us to include the entire community in this. Reduction of total costs of care. That's a big question, because what do you include in total costs of care? In many cases, if it's an integrated network that is the accountable care organization, they are counting the costs of care that they are incurring. What about all the costs that are happening out in the community outside of the healthcare system? And that's what we are trying to include in the Minnesota or in Southern Prairie Community Care. So regardless of who holds the contract and receives the money, the same components are needed. The patient-centered medical home concepts, whether or not people become certified, is another issue. But we really believe that many of those concepts really are fundamental to what we're going to do. That central place where people can go for their central care coordination with the care coordinator there, the primary care provider, having that extension into the community. The electronic tools are very important. We know that people communicating with one another is extremely important. Given all of our 12 counties and all the providers in our 12 counties, because many of them are rural, very small, they are, many of them have grassroots sort of very basic EMRs. The Health Information Exchange that we are using has spoken with all of them and is designing an exchange that will allow them to speak and transition information. People are not going to have to change their EMR. That's the beauty of this, is that when they look at their EMR every day, they open it up, it will still look the same as it always has. Everything that happens with the Health Information Exchange is behind the scenes. A common plan of care. Now, this is not easy to do. I don't know if any of you have tried to do this, but if you go from social services, public health, home care, WIC, it doesn't matter, mental health, into primary care, everybody has a different concept of what information is really needed. So we've been holding a group of community care team meetings in each of those communities, bringing all these folks together and saying, what do we really need? As we transition, when a patient leaves a hospital and goes to an subacute rehab, what information is needed for you to accept that patient? When we had a room about the size of this, or maybe a little bit smaller, of folks from those communities, and I would ask a couple of questions. How many of you consider yourselves care coordinators, or you do something involved in the care coordination? Almost all the hands went up. If I ask a question about when you receive a patient is referred to you, how many of you would say that you receive all of the information that you need with the referral? No hands go up. So how do we fix that? And so the idea is, let's create a common care plan, I know that the continuity of care document, CCD, has its certain list of information that should be included on that. But as a community care team, what do we want our care plan to look like? And we know that there are regulations that require certain things for everybody to include, but that's not necessarily the information we have to share with one another. So what do we need to share with one another? And then the data. Well, first of all, the data resides in the cloud. So you go up and you access it. You don't, the cloud, the information doesn't get pushed at you so that you're constantly having to look at this. There's just a little icon that shows up as maybe red that says there's something new that you might want to look at. But that's all. We have condition-specific information. We have utilization patterns. And then we have point-of-care data. So there's like 3 levels of data that we have that's available. And people can access that as needed. And then the cooperation of the hospitals, providers, counties, and nonprofits. This is really fundamental to the whole concept of a community care team, is bringing everybody together, and everybody has to participate. Now, in one of the areas, I will admit that we do have a provider group that has not yet decided to participate. They're sort of waiting to see. And I think that you always have people who are the early adopters, and then you have the late adopters that are going to say, I'm going to wait and see what happens. In many of the communities, they would kind of look at each other and they'd say, you know what, if Terry does it, I'm going to sign up. If he doesn't do it, I'm not going to sign up. So there's sort of like the community leaders. We have all, except for one provider, we have all of the providers and hospitals and counties and mental health providers in those 12 counties signed up and agreed to participate in this network. So we're really excited about that. We are in the implementation phase. And with that, I want to conclude. Hubert Humphrey actually grew up in this area, so it's really kind of fitting that we use a quote from him. The moral test of government is how government treats those who are in the dawn of life, the children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped. Thank you. Yeah, do we have time for questions?
Oh, I was asking about the common care plan, who was in charge of it and where's that housed and who gets to add to it and et cetera.
Yeah, so the common care plan, so Southern Prairie is facilitating all of these folks from the community coming together. And the discussion there is, let's develop this from the grassroots. You guys are the ones who are going to be the recipients of this information. What do you want to be on that common care plan? So we're starting to hone that because we've had 2 work groups or 2 meetings in each of the communities, and we're pulling all that information together. Then the information will be available in the cloud through the Health Information Exchange. So we have a vendor who's providing the Health Information Exchange, and people will subscribe to a particular patient. And then obviously all of the HIPAA compliance, all of the privacy and security issues are in place. We have all of the appropriate firewalls. You don't have access to a particular patient unless you actually are a member of their care team. So it's not globally accessible to everybody. You have to be part of their care team. And obviously we have to ask patients to provide consent. Each of those providers needs to have consent for release of information. So that stuff is all in place in the same way you would for paper, but we're just doing it electronically.
Thank you for your presentation. On your slide about the community care team, and you had one bubble with all the internal stakeholders, behavioral health and primary care in the hospitals, and then external to the organization. Can you speak to insurance and insurance plans, and how does that fold into your care coordinum?
Yeah, actually, I'm glad you brought that up because, yeah, the insurance plans, we actually have 2 primary insurance companies that we're working with, so Blue Cross Blue Shield and UCare. They are still the carriers, so they're still the ones that provide the insurance for this population. But we're providing the care coordination services. We're working very closely with them, particularly Blue Cross Blue Shield. They've been at the table, so they've been part of this discussion about a community care plan. Because they have people who reach out to these patients, they're very interested as well to try and figure this out, because the thing is that we've got so much duplication. It's duplication, it's confusion to the patients, it's extremely inefficient. So if there are ways that we can reduce that duplication and help us all kind of come together and provide the same kind of message to the patient so they're not confused. I mean, I think particularly if you think about somebody like Bill, if they have 5 or 6 different care coordinators and none of those care coordinators are talking, it can be extremely confusing to them.
When you were talking about the categorization and care coordination, the steps going through and looking at risk in your patient population, and you were talking about looking at them from a clinical perspective, are you also using risk adjustment models based on payer claims? What kinds of things are you doing to assess risk? And who's doing that? Who's involved in that particular part of your process?
Yeah, there's actually 2 levels of stratification and risk. So one would be at the entire population level. And that will be, I mean, the vendor that we're using is actually Sandlot out of Dallas. And they will be doing that overarching analysis of the data, looking at claims and high utilization costs and pharmacy costs and all of that stuff. We have a spreadsheet that's probably 8 feet long if you actually printed it out of different fields of information that they would be assessing that risk with. The second level of risk is at the PCP's office with the care coordinators and all the folks within that and the folks in the community coming together and saying, okay, what is this person's level of risk based on additional factors that you're not going to get in claims data. So they'll be obviously looking at just-in-time data, but also looking at some more socioeconomic, psychosocial issues, as I mentioned. Interestingly, and I did not bring this up, but this particular area, one of the counties has the highest percentage of non-English speaking population in the state of Minnesota. We have a huge Somali population, East Africans moving into the area. They have a lot of places where people can get good jobs. That's why they move to that area. But that adds another layer of complexity. So we have the need for interpreters, mental health issues, post-traumatic stress disorder. All of those are considered part of the assessment that would happen among the care team for the patient. So population level and then patient level assessment.